Thank you all for inviting me here today. Actually, Matt had invited me last year and I wasn't able to attend, unfortunately, so I'm happy to be here today. Windsor's actually my hometown, and so it's really a great pleasure to me to see so many libertarians in my hometown, because the politics of Windsor are not conducive to ideas about liberty. But an interesting story about my affiliation with the Fraser Institute is that's exactly the same story for Michael Walker, the founder of the Institute. He's originally from Newfoundland, and being from the Rock, politics are similar there as they are here. Blue-collar economies, very dependent on union politics, those kinds of things. So Mike saw a problem with poverty in Newfoundland and wanted to solve that, decided to study economics, and saw some answers in free markets that could help his fellow Newfoundlanders. He then moved to BC instead, and decided to help people who live in BC because they were under the pressure of an NDP government at the time that was making some decisions that Mike felt was very destructive to economic freedom. So very similar sorts of stories. People who live sort of behind enemy lines, I guess, tend to have more incentive to do something about it. What I want to talk to you about is the idea that liberty and individualism, two values this crowd espouses and represents, are actually counter values to the existing healthcare system in Canada, but also represent practical solutions. So most people in this room would argue that if we freed Canadian healthcare, if we took out the public healthcare monopoly, if we allowed people choice, that on a moral level, that's good enough. Who cares if it works better? It has moral value, inherent moral value. But what I would argue is that it not only is the moral things, the moral ideal, but it's also very practical in terms of the economic outcomes that it would produce. So let's start, I guess, a little bit by going over the policy structure of Canadian healthcare and sort of thinking about that in terms of the values that it represents. First thing, the Canadian healthcare system as it currently exists is based on the restriction of freedoms. Essentially, you could describe our healthcare system as a government-run health insurance monopoly over hospital and physician services. Technically, what it says in the Canada Health Act is that all medically necessary services must be publicly insured. Well, what is a medically necessary service? That's determined by governments by a sort of fiat, arbitrary nature. But what it ends up meaning in practical terms is hospital and physician services. The Canada Health Act essentially threatens to reduce federal transfers to any province that does not maintain a public health insurance monopoly over medically necessary services, as I mentioned. It would also impose a reduction of federal transfers on any province that charges user fees for the use of publicly insured health services, or any province that allows healthcare providers to charge an extra payment, what you call extra billing, over and above the publicly insured reimbursement rate. So essentially it's restricting freedoms for people to access healthcare by paying privately and for providers to receive private payment. Provinces in turn make this illegal. It's not actually the Canada Health Act that makes it illegal. The Canada Health Act is sort of a bribery mechanism. The federal government says, hey, look at all the billions of dollars we could give you. You wouldn't be responsible to your voters for, because we're sort of hiding behind this accountability split on federalism. But we'll give you all that money in exchange for this policy structure. It's the provinces themselves that pass legislation to make this stuff illegal. And essentially do so by threatening providers. And they say, if you take extra payment above the public reimbursement rate, if you charge user fees, or if you take private payment in addition or parallel to the public system, you'll lose your right to build a public insurance system. So that's how the mechanism works. The end result, however, is that it's effectively illegal for Canadians to pay privately for services covered by government insurance. Actually, I'm going to put this down. Can everybody hear me without it? It's effectively illegal for Canadians to pay privately for healthcare. It's done through these various mechanisms, but it's illegal even when those services are rationed. So that is, even if the government says a certain procedure is covered under public insurance, but you have to wait 18 weeks or 3 years to get that service, you still can't pay privately for it, even though they're not fulfilling their promise of covering it. So essentially what this has resulted in is a restriction to the right to life and security of the person. This has been recognized in a Supreme Court ruling in June 2005 in a case called the Chuli case. And most of you are probably familiar with this. Of course, Jacques Chuli being a physician, working on behalf of a patient, George Zeliotis. Patient couldn't get access to publicly insured services, argued that the ban on private payment represented a violation of rights to life and security of person. The Supreme Court agreed. They agreed only on the basis of Quebec legislation, though, and not on the basis of the Canadian Charter, so it doesn't apply in other provinces yet, but there's an ongoing court case that we can discuss afterward that might push that forward into other provinces. So not only do we have the rights of patients effectively limited, but we have the economic and property rights of healthcare providers themselves also restricted by Canadian healthcare policy. So one of the values of Canadian health policy is to restrict freedom. Secondly, it's based on egalitarian collectivist values. Again, not individualist, not libertarian. It is taxpayer funded and is based on the forced redistribution of people's wealth. That is, you don't pay for your own health care, your neighbor pays for your health care, and you pay for your neighbor's health care. It's done so, of course, through coercive taxation. The legal ban on private payment is also a way to ensure egalitarianism or equality of outcomes. You can't pay to have quicker access to service, you can't pay to obtain better service, you can't pay to obtain more services or more goods. You're just simply prevented from doing so by the public monopoly and the ban on private payment. And of course, this leads to free rider problems where we don't have individualism in the sense of individual responsibility. We have people who are consuming things without paying the price of those things. In other words, we're, again, paying for our neighbor's consumption of health care. So we have these two sets of values, egalitarian collectivism and restriction of freedom. Thirdly, the Canadian health policy structure is based on the value of altruism. I'm assuming there's some Ayn Rand fans in the room, and you're familiar somewhat with her concept of altruism. It's not about helping, she's not opposed to people helping the poor or charitable exercises. She's opposed to the value concept that somehow people are obligated on a moral level to sacrifice themselves or their property for others. The Canadian healthcare system, however, is based on that very concept. There is an ideological aversion to for-profit delivery of healthcare. So basically, in Canada, we say it's okay for someone to make huge amounts of profit as an entertainer, as a musician, but it's a terrible thing to make huge amounts of profit for making sick people better. That's essentially how Canadian healthcare works. Of course, it ignores the fact that the wages paid to healthcare providers like physicians and hospital administrators and left-leaning health policy researchers, those are all profit to them. Those wages are not delivered on an altruistic basis. They're also profit, but those kinds of profit apparently are okay. And of course, there are perverse incentives created by restricting the profit motive. It leads to inefficient allocation of resources, inefficient production, and so on and so forth. But essentially, in a nutshell, the Canadian value system is based on the Marxist view of to each according to need and from each according to ability. And this gets reflected in a fourth area of value, which is the use of force. If the Canadian healthcare system is based on the idea that people shouldn't make profit from delivering healthcare services, from making sick people better, how do you get them to do that in the absence of a profit motive? But you employ the use of force. That's how you do it. And it really, essentially, it's the requirement for compulsion to achieve the same or similar goals that you would achieve through positive incentives under the profit motive. And you can see this reflected in labor relations under the central planning mechanisms of healthcare in Canada. First, governments exploit medical labor. Physicians, general practitioner physicians in Ontario, for instance, if you adjust their earnings today for inflation, in other words, put it into real economic terms, it hasn't grown since the early 70s in real terms after inflation. That's the salary and earnings of our general practitioners. If you look at the earnings of our physicians in general and compare that to what we consider sort of a quasi-market price in the United States, it's sometimes 1/3 as much as what a doctor could earn simply by crossing the border to a freer market in healthcare. And I say freer because the US market is not a totally free market for anybody who's familiar with it. I'm no advocate of the US approach either. But what this results in, this exploitation of medical labor, is that doctors and nurses will either leave the country or they will, if they decide to stay, they will perhaps organize against the government in order to pressure for wage increases. And the result is that labor can effectively hold the entire system hostage because it's run under central planning and a public monopoly that exists province-wide. So if nurses, for instance, go on strike, they go on strike as a group. The entire population of nurses in the province negotiates with the central planner. So what happens? Well, you just can't go to the next hospital down the road if you could, as you would in a free market. If labor withdrew its services at hospital A, you would just simply go to hospital B. But when labor decides to withdraw its services or run other kinds of work actions under this system, the entire system is held hostage. So again, force is applied to physicians and nurses in our system in order to extract gains or savings on cost so that wages are held down to below market levels. Labor then responds with the use of force. Finally, the governments will legislate servitude. They'll simply legislate people back to work. And these are how human relations operate under Canadian healthcare, through the use of force. Because the system doesn't operate right because of the other values that I've already outlined here for you. So what are the results then of this kind of a value system? Well, that's what I'd like to present to you with a series of slides today. There are really, I guess, 4 things to discuss in terms of results. 3 are the actual results, and the 4th is why nothing actually changes. So let's just sort of go over some of the evidence of what is happening in Canadian healthcare. What do we get from this system of values that are counter to liberty and individualism? Well, we get declining value for money. What I mean by that is, what do we spend and what do we get in return? If you spend $150,000 on your automobile and you drive an Aston Martin, you're probably doing pretty well. But if you're driving a Hyundai, or dare I see a minivan in Windsor, then you're probably not getting a good deal for that $150K. So what matters is not how much we spend on healthcare, but how much value we get for the money we do spend. So at the Fraser Institute, what one of my colleagues, Nadim Esmail, does is he compares the spending in Canada to other OECD countries with similar social goals. That is, he excludes the United States and Mexico because they don't attempt to achieve universal health insurance coverage. But all of these other countries do. And so we can compare to them on an apples-to-apples basis. What do they spend? What do we spend? What do they get? What do we get? And if you adjust the health spending as a percentage of GDP in these OECD countries to reflect the age distribution in their population, that is, you'd expect some countries to spend more proportionally on healthcare because they have an older population, a greater number of people above the years of 65. There's a correlation between age and spending on health, by the way. And if you adjust for that so that you're actually comparing on a fair basis between these countries, you'll see that Canada is the second most expensive in terms of health spending as a percentage of GDP, second only to Iceland. Now that's not necessarily a bad thing. As I mentioned, it matters what we get in return for that kind of spending. And this is what we get. This is a bar graph representing the wait times in the provinces. And on the far right, we have 2 bars representing the national average here. This is the wait time across 12 specialties, all provinces, the wait time between an appointment with your general practitioner or family doctor and the moment at which you actually receive treatment by a specialist. And the dark bar is 1993, that's the wait in 1993. The light gray bar is the wait in 2006. You can see the average for the country here. It has almost doubled since 1993. People wait almost double the length of time that they did in 1993. So we spend a lot relative to other countries, and that is resulting in what? Shorter waits, stable waits, no, longer waits. So what do we get in terms of other resources for our money? Doctors per population. Well, this is Canada's rank here in the black bar, and you can see relative to other OECD countries with similar social goals, we have a fewer number of doctors per population in Canada. In other words, patients have less access to physician services in Canada than all of these other countries that are above this dark bar on the graph. So we spend a lot, but we're getting few physician resources in exchange. What do we get in terms of diagnostic technologies? Again, Canada's rank is represented by the black bar. And you can see that at best we're in the middle of the pack here, but based on the length of some of these bars for a country like Japan, we're way behind what patients actually are enjoying in countries like Japan. My colleague Nadim Esmail likes to say that in Japan there's an MRI machine in every 7-Eleven. Which is, who knows if it's a good thing. We would know if we had a market, because the market would determine that through preferences. But you can see we're not getting good access to modern diagnostic technologies. Here's another example. It's just CT scanners, and you can see Canada's rank is also very low relative to the same group of countries. So what do we get in terms of wait times? We get long wait times, we get poor access to physicians, we get poor access to medical diagnostic devices. We also get poor access to medicines. This bar graph shows the amount of time that people have to wait to access a drug after it has been developed. It takes like 10 years to develop, on average, it takes 10 years to develop the average drug. After that period of time, governments have to approve it as safe and effective. And after that, they make decisions on whether they're going to pay for it through public programs. And this bar represents that time, the time that it takes for them to decide that the drug is safe and effective and you should have permission to use it. So you can't decide that for yourself. They're very paternalistic. And then whether they're going to pay for it after deciding or after promising that healthcare in Canada covers all medically necessary goods and services. So we have a long period of time here. For biological medicines, it's almost 3 years, and it's well over 2 years for pharmaceutical medicines. On average, you're talking about 2.5 years that people who are dependent on public programs have to wait, and people who can pay out of pocket or have private insurance wait this period of time that is represented by the darkest part of the bar. Again, very poor access to medicines. And you can compare that to other countries. We compared in a recent study to the European Union. We also compared to the United States. And wait times to access new medicines, just to have our government approve them as safe and effective and give us permission to buy them, is longer in Canada than it is in the European Union, which, as we know, tends to be thought of as a more socialist environment in Canada, which in this case it is not. Or at least it's more efficient with their socialism than our socialism is. And the US FDA does better. But what this graph shows is governments make, through the Canada Health Act and through various provincial legislation, they make the promise that Canadian healthcare will comprehensively cover everything that's medically necessary. And then they argue that some drugs are not medically necessary. Health Canada said they're safe and effective for use. They actually are effectively treating what they intend to treat, and they're safe. Toxicity levels are low enough. And yet when the provinces have their opportunity to pay for those things, they don't. Less than 20% on average of the drugs that are submitted for approval, after Health Canada says they're safe and effective, actually receive those kinds of approvals. So what it represents, I'm not advocating that we should pay for those things publicly. What I'm trying to communicate here is the failure of our system as it exists. The values I listed lead to this kind of result. So we get declining value for money based on the values of Canadian healthcare. We also have a lack of financial sustainability, and we're approaching a tipping point, so I expect that this issue will become, it is the leading issue right now driving health policy. And this is what I mean by sustainability. The red bar on the right represents the average annual rate of growth over this 5-year period, the most recent years that I had data available for. We update this every year. 2001 to 2001-02 to 2005-06, there's a fiscal year, that's why we split it like that. The red bar represents the average annual growth in public health expenditures. So this is not private health expenditures. This is just what governments spend on healthcare, or Medicare expenses, plus drug programs. You compare that to their ability to pay for it. In terms of their absolute ability to pay for it, in terms of growth in the economy, if you assume that government should always have a permanent share of the economy, the ability to pay for it from that tax, those taxes, will decline over time because public health expenditures are growing faster than the rate of growth in the economy, our ability to produce wealth. It's also growing faster than the rate of growth for all the other goods and services in the economy, which is represented by national CPI, or Consumer Price Index. And it's also growing faster than the actual ability of the provinces to pay for, which is provincial total revenues from all sources. And that includes federal transfers. And so it's just simply not sustainable if this continues. And so what we see is that it's not just the national average that's being reflected there. That graph did show a national average, but this is the same situation in all provinces. The red bar represents the growth in public health expenditures in the provinces. The green bar, the growth in their total revenues from all sources. In every province, public health expenditures are growing faster than revenues. Is unsustainable. So what does it mean? What it means over time is that public health expenditures will consume a larger share of the available revenue in every province over time. And we can see that the yellow bar represents the percentage of total revenue in each province in 1997. The red bar represents that same percentage in 2006. It has gone up in every province Some of the East Coast provinces like Newfoundland and Nova Scotia are really, this is a little bit of an illusion here of that gap being narrower because they got some recent benefits. They swung a sweet deal with the federal government on equalization. They got a boost to their revenue base from the discovery of oil. That kind of growth will not happen in the future, and you'll see the red bar, it'll be a dramatic growth in the gap between the red bar and the yellow in those provinces. But you can see that that's what's happening. Healthcare is consuming more and more of our available revenues. Well, you can sort of imagine what governments are thinking in terms of tax increases for that. Here's Ontario, just as an example of one province. You can see that by the year 2020, public health expenditures are on pace to consume 50% of all revenues available to the province. By 2020. Nearly 2/3 by the year 2035, and theoretically 100% of all revenues by the year 2056. So I get criticized on this analysis by many people. On one basis, they say, well, this is a short-term trend. It's not a long-term trend. In fact, it's the trend of Medicare for over 30 years. Since the beginning days of Medicare, for as long as we have data, it's the same trend. We paid for it through deficits and borrowing money in the 70s and 80s. Once we figured out that that was going to bankrupt us, we tried to pay for it through tax increases. And then once we figured out that nobody wanted that, we tried to cut back on healthcare, creating wait times, physician shortages, lack of access to diagnostic technologies, not paying for new medicines. That's what we get from the value system of Canadian healthcare. So these projections are conservative. I don't think there's any doubters in the room, but in case there are, because there often are, public health expenditures here include all rationing and reorganization to date. The medicine's not paid for. The medicines used to be paid for, but now are no longer paid for. That surgical procedure that we used to say is medically necessary, but humans evolved, we don't want to pay for it anymore, so it's not medically necessary anymore. We'll get rid of that, but it includes all of that. These assumptions are just what I observe in the Stats Canada databases, and I just project that forward. I make no adjustments. In fact, they don't even adjust for the age of the population. As the population ages, health expenditures will accelerate because 50% of per capita lifetime expenditures occur after the age of 65. As people get older, health expenditure, demand for health services will grow and health expenditures will grow with them. So I've actually underestimated the growth because I haven't included that in my analysis. It's actually worse than what I've showed you. Total revenues include all federal transfers. So if you think the feds can bail out the provinces, you're just wrong. They've tried, it hasn't worked. And if you think tax increases are good, which I'm hoping in this conference, of all conferences, nobody thinks that's good, that won't work either because governments have raised taxes. And the tax freedom day in Canada has shifted later and later in the year since the mid-90s. So also the total revenue base is actually overstated because we have to pay for outstanding debt services costs. That means paying for the interest on outstanding debts. And if you subtract that from available revenues, you actually have less available as a base of revenue with which to pay for healthcare and education and anything else that people think government should be paying for. And of course, a smaller working population going forward means less revenue for governments as well. So the revenue base is actually overstated. I've been really generous, in other words, to the governments on what I expect from revenue growth. And I've really understated. I've really been generous to them on what I expect from health expenditure growth. Even so, it shows that it's unsustainable. And so that's a problem. So I've been accused by the president of the NDP party, who now runs the TTC in Toronto. I've been accused by Adam Giambrone of being a scaremonger. So I thought, well, I should probably get a list of other scaremongers together to see what kind of company I'm in. And this is the other scaremongers in Canada who are saying that healthcare financing in Canada, under Medicare, under the current structure, is unsustainable. Look at all the government people saying this. This is not crazy radical Brett from the Fraser Institute. We have all these government folks who recognize it too. The Clare Commission in 2000 in Quebec, the Fight Commission in Saskatchewan, Mazikowski in Alberta, Kirby Senate report. Saskatchewan's former finance minister, Janice McKinnon, published a paper in the Institute for Research on Public Policy saying that it was called the mathematics, arithmetic of healthcare, saying it was unsustainable. The Menard Commission in 2005, Aon's a consulting firm hired by the Alberta government, which told them it was unsustainable. And most recently, the Minister Taylor in BC released a report that said that 71% of all revenues would be consumed by healthcare expenditures in BC, provincial healthcare expenditures, by the year 2017. So it's even more radical more crazy right-wing stuff than what comes out of me at the Fraser Institute. And of course, there's all the private sector people who have been saying the same thing, a number of us at the Institute using various methods of measuring this for hospitals, for the system itself, versus program expenditures, etc. Whatever method you use, it shows that it's unsustainable. So that's there for people who are doubting. Thirdly, what do we get in terms of these values of Canadian healthcare? What does it produce? Declining value for money. It produces an unsustainable healthcare system. What we end up with is that governments are shifting the blame. They don't want to admit Medicare's failures because A, they find a political cost to that, and B, they might be ideologically predisposed to believing in the Medicare system. But they're in an ideologically imposed state of denial, and blame has over time been shifted to what I call, well, I shouldn't say I call, Cheryl Cohn from Consumer Arthritis Experts calls it this, and I've asked her for permission to borrow it, so there's no intellectual property violation. She calls it the three evil empires of medical care. First it was doctors, then hospitals, and now medicines. So what happens when Medicare fails your great socialist utopian enterprise? What do? You blame physicians. You say, well, we spend too much money on doctors, right? So GP wages have been unchanged since the early 70s after inflation. We've held down their wages. We've exploited medical labor, something Marx said that capitalists do. Health professional wages relative to the US are 1/3 to 1/2 as much. We've let our hospitals' infrastructure deteriorate. The average age of an Ontario hospital, according to the OHA, is 40 years. The average age of a US hospital, by comparison, is 9 years. How old is Medicare? 40 years old. We confiscated the healthcare system. We didn't renew it. So that's how we've been trying to achieve savings. So that's what governments do. They shift blame. Oh, we spend too much on physicians. We spend too much on hospitals. They also say we spend too much on drugs. The reason they say this is because of this graph. And we can see the growth rate in various components of health spending, public health spending. And you can see that prescription drugs as a group are growing at a faster rate than any other component of health spending. That's interesting, but what does it mean? Well, if we compare how much we spend as a proportion of the budget on prescription drugs relative to those other things that are growing admittedly at a slower pace, what do you see? You see that prescription drugs, patented and non-patented prescription drugs, brand name and generic in other words, we spend less on those things than we do on any other category of spending. Hospitals and institutions, professionals would be physicians and other professionals, and the category like other, which would be public health spending, research, and so on and so forth, administration. So we're spending less. Even worse is the argument that patented medicines or new drug inventions are the real cause of escalating healthcare costs. Well, let's break it down and let's look at what percentage governments spend of their total health budget on patented drugs, new drug inventions. Drugs that have what some people like to call a monopoly over the market, which is not really a monopoly, but just a protection of a property right. And I can get into that in question and answer why I believe that. But you can see that government spending on patented prescription drugs is only 6.8% of what they spend as a total. It's just simply not statistically possible for drugs to be blamed accurately for the unsustainable growth in public health expenditure. It just simply represents too small a percentage. But if you don't believe me, we can take drugs right out of the picture. We can say, what if we spent zero on pharmaceuticals? On all pharmaceuticals, not just patented drugs, but non-patented as well. Well, everything else is still growing at an unsustainable rate. Even if we spend nothing on drugs, healthcare is unsustainable. The three bars on the left represent professionals, hospitals and institutions, and other health expenditures, all growing faster than the rate of growth in the economy, the rate of growth in prices for all other goods and services, and our ability to actually pay for this through tax revenue, total provincial revenues from all sources. This percentage is different, by the way, because it's a different period that I'm measuring here. You can see on the left, different years, different from the previous graph. But you can see that this demonstrates that even if we spend nothing on drugs, everything else is still growing at an unsustainable pace. And in fact, as drugs have increased over time as a percentage of public health expenditure or government health expenditure, I have here GHEX, we see that the rate of growth in public health expenditure or government health expenditure is virtually unrelated to it. There's no relationship whatsoever. It goes up in some years, down in others, and yet the pattern for drugs is to take up an increasing share. The reason is because drugs are a technological positive substitution for other kinds of healthcare. They complement healthcare, reduce time spent in hospital, or they replace other kinds of treatment like surgery so people don't spend as much time in hospital. So it doesn't really affect the overall growth rate for the mix of the components to change in this case. So our governments have blamed doctors, hospitals, and drugs. And I've argued in many interviews on the radio, for instance, I said, well, let's spend nothing on any of those things. Let's not have any doctors, hospital, or drugs. And then we'll have an affordable, sustainable healthcare system under Medicare. And that's really what they're proposing. Follow the logic of what they're saying, right?
Or the administration by the administration.
Yeah, exactly. So why does this happen? Well, the reason it happens is simply because of the politics of redistributive taxes. In other words, this coercive use of force by governments. Why do they resist economically rational things that would save or make our healthcare system sustainable? Things like user fees and parallel private insurance. The reason is the bulk of the tax burden is carried by a minority of voters. 1/3 of the population pays 2/3 of all personal taxes in this country. This table breaks down the population by family income deciles. That is, 10% of the population is in each decile. So on the far right, we have the upper 3 deciles, or 30% of families. That upper 30% of families pays almost 2/3 of all taxes. So it's just simply more expedient for a politician, less costly politically, to raise taxes on those people and lose potentially 30% of the voters than it is to impose a user fee on everybody or tell everybody they're going to be responsible for their own healthcare consumption through private insurance. Secondly, there is the politics of illness to consider. How do governments get away with restricting access to healthcare in order to try to maintain the facade of sustainability, the facade of value? Well, they do this only because sick people don't represent a lot of votes. First of all, I can tell you less than 10% of the population, declining over time, is hospitalized in any given year. So a hospital wait means nothing to 90% or more of the population in any given year. But those who are really truly catastrophically ill represent a very small percentage of our society. This is the breakdown of spending in Nova Scotia. It's approximately 1 million records per year over 7 years. I could follow a person's Medicare number anonymously over that period of time and determine how much health care they used. And as a proxy, I took the value of the payment to physicians and used that in the database to calculate the actual expenditure per person. And what I found was that nearly 21% of the population of Nova Scotia in any given year never spent a single dime on a physician. They were healthy. They never went to the doctor at all. 96 or more percent of the population spent less than $1,500 per year on physician services. This is Roy Romano's NDP-style definition of a catastrophic level of expenditure for drugs, so I just simply used it here for general health expenditure. So over 96% of the population is so healthy that they spend less than what we consider catastrophic expenses on healthcare. So what do they care if the healthcare system is broken? They don't even know it's broken. They hardly use it. They don't use it enough to make an issue out of it. But 4% of the public spends more than $1,500. These are the people who, quite frankly, are dying in hospital beds in the middle of hallways instead of getting into a room to see a doctor, or they're not getting access to healthcare quick enough to make it useful for them. Many people, in fact, get removed from waiting lists because doctors determine that they can't be helped at a certain point. There's no point in being on the waiting list. So sick people simply represent too few votes to register on the radar of politicians. When you're sick, you're not a political activist. You have very few people representing you in terms of voice. Maybe a few patient advocacy groups, who Debbie Chakrabarty, who's worked with me on this, can tell you their task is very difficult. But this is why nothing changes. So, more to the point of what I came here to talk about today, values versus counter-values. I talked about the supposed values of Canadian healthcare. I say supposed because what I'd like to talk about is something that is really valuable, which is liberty and individualism. Liberty and individualism represent counter-values, but also practical solutions to Canadian healthcare problems. As I mentioned, they represent something that has inherent value on its own. I'm a libertarian myself, and I can, on a libertarian sort of philosophical level, say that freeing up healthcare is just good, whether it works better or not. It's just good because it respects what is necessary for human survival in a very philosophical sense, people's individual freedom and liberty. But it also represents a practical economic solution to the problems that we see, the lack of access to physicians, the wait times we see, the lack of sustainability, etc. So what could we do to introduce liberty and individualism as counter-values and practical solutions to Canadian healthcare that would represent, first, an incremental step from the status quo? Not a radical change, but just introduce some individual liberty into Canadian healthcare. Well, first, we could legalize private payment. As I mentioned, it's currently illegal in Canada, but we could allow parallel private health insurance options like we do for education. If you want to send your child to a private school, you pay your taxes for the public system, but you're allowed legally to pay private tuition to send your kid to a religious school, a school that produces better education, a safer school, a closer school, a richer school, for whatever reason. You're allowed that freedom with education, but not with healthcare. Let's bring that sort of freedom into the healthcare system, and at least let people opt out of being stuck in that system, even though they're still stuck with the tax bill for it. That's an incremental change. Not the ideal, but incremental. We could also allow extra billing, allow people to pay over and above the public reimbursement rate to physicians, other providers, to bring in appropriate economic incentives for efficient allocation and for the provision of healthcare services. We could also reduce the unfair free rider problem. I say reduce but not eliminate, which is a problem of collectivism related to the Canadian system. We could, first of all, introduce the user pay principle when we introduce private health insurance options. Private health insurance is not funded through tax redistribution, but it's funded through premiums. In other words, it's based on your expected use and your actual use of health care. In some cases, it may be based on a community-rated or flat-rated premium, which is not based on your use or expected use, but just on a per capita division. Either way is more fair than what we have now, which is tax redistribution. We could also introduce user fees for publicly funded health care so that people would be responsible for their own use of those services. Again, reducing the unfair free rider problem related to Canadian health care. And I mentioned the flat premium financing through the public health insurance. We could also apply that to the public health insurance scheme as opposed to tax redistribution. So that is what we could do incrementally. But what can we do on a more radical level? Well, we could achieve universal health insurance coverage in Canada, which is, I think, politically, if you want to think practically about this, we can't go beyond the idea that people will accept something less than universal health insurance coverage. It's the basic sort of social underpinning to healthcare thinking in Canada today. But can we at least, after achieving universal health insurance coverage, what's the most radical maximization of individualism and liberty that we can achieve? Well, we could go for universal, compulsory private health insurance, which is the Swiss model. In Switzerland, they operate their health insurance on the same principle that we operate our auto insurance. If you want to drive a car, you have to buy insurance. As a libertarian, I'm opposed to the compulsory aspect. When it comes to this movement from the status quo, it's a good alternative. Okay? It improves things for everybody, and it's something that I think we can achieve. So in Switzerland, if you want to live in Switzerland, you have to buy health insurance. Just like if you want to drive a car here, you have to buy auto insurance. If you can't afford it, they give you a low-income subsidy so you can afford it, which is the real problem. Some people can't afford to buy private health insurance. That's the problem that created the rationale for Canadian-style healthcare. We don't need a public monopoly to achieve that. We can do so by minimizing the role of government as much as possible and maximizing individual liberty and choice as much as possible, and end up with a system that is far more sustainable and produces a far higher level of value for money. So those of you who are uncomfortable with the compulsory aspect, I would ask you to consider this. In practical terms, moving from the status quo, this is an improvement. It's making things better for everybody, absolute gains for everybody. And consider the alternative. Currently, force is applied to make you pay for your neighbor's health care. If force is going to be applied, wouldn't it be better to force your neighbor to pay for their own health care, or at least a greater portion of their health care? So, again, it's not ideal. I refer again to my libertarian credentials here a little bit. But in practical terms, we can achieve something that will improve choice and liberty for Canadian patients by moving to a Swiss model. So some of the advantages to moving in this direction would be to increase individual liberty and choice, of course. It would be fairer because it would increase an individual user's responsibility for the cost of their own consumption. It would encourage rational demand for healthcare goods and services. That is, people wouldn't consume more than they actually believe they need. And it would encourage the efficient allocation and substitution of the components of healthcare. All basic principles of user pay and economics. There are some glimmers of hope moving toward change in Canada. The Chihuly case I mentioned earlier has opened the door to this parallel public-private system similar to the public-private education model that we know of. There's a case ongoing in Alberta right now that is challenging on the basis of the Canadian Constitution and not on the basis of provincial statute, applying the precedent set in the Julie case, which I think this case will be successful. In my opinion, it will be successful. If I had to put some money down on it, I would put money down on it being successful instead of going to the casino. I think the odds are better. And in terms of the trend of health care reform in other countries, that trend is leaning, even in countries like Sweden, toward privatization. I had lunch with someone in Vancouver a few weeks ago. He's from the Swedish Consulate Office of Science and Technology. He's based in LA. He came to visit me in Vancouver. We went to lunch and we talked about privatization of healthcare in Sweden. I said, well, when is Sweden going to make private health insurance legal? What do you mean when? It's already legal. Oh, when is Sweden going to allow for-profit private provision of publicly funded services? What do you mean? It's already legal. So these things have already happened in a country like Sweden, which is often touted as a socialist paradise by people on the left in Canada. But they have realized the error of their ways long ago, and they're moving away from their socialist-style healthcare systems. That's happening right across the OECD, and in fact, we even see in the United States some movement to adopt Swiss-style health insurance programs, which, from their status quo, one might argue is not necessarily a plus, but it will certainly solve their other problem, which is possibly ending up with a single-payer system. We also see, I think, a glimmer of hope from the fact that our own VIPs, our own MPs and MPPs, our politicians, actually endorse private health care privately. When their health is at stake, they go to a private clinic. When their health is at stake, they go to Shouldes Hospital to get their appendix out, as Jack Layton did. Paul Martin attends private clinics. What did Robert Bourassa do when he had cancer? He went to the Mayo Clinic in the evil United States free market healthcare system. So these endorsements are important because they're symbolic, and the public can see through the BS when a politician says that we should maintain a public monopoly. When they're saying, do as I say and not as I do, people see through that. So that's a glimmer of hope. Politicians don't want to sacrifice their own health for their supposed ideals. And there's also, I think, related to that and to perhaps taking a little credit to the research at the Fraser Institute and perhaps people like yourselves who are committed to promoting the values of liberty and individualism, there is a growing public awareness on the part of the Canadian public that our healthcare system fails to achieve its own lofty promises, so it's a lie. It also fails to achieve what they expect from modern healthcare system, that the costs of these things are real in terms of human health costs, not to mention the tax dollars that are wasted. But they're also becoming increasingly aware that we don't need to do it the way we have done it in the past. And if we continue to do what we always did, we're going to continue to get what we always got, or less. And I think Canadians are becoming more and more aware of that. So I just like to end on that hopeful note and then open up the floor and take some of your questions. Question in the back first.
Do you know the name of the Alberta Court Challenge?
No, I don't, but you can contact the Canadian Constitution Foundation, led by a very bright young guy who Debbie might know the name of, but I can't remember.
John Ross.
No.
John Carpe.
Carpe, that's right, John Carpe. Yes, I knew the name, it just slipped my mind. Contact John Carpe and he can tell you about supporting that in terms of the Legal Defense Fund and anything else that would be useful. Moral support is important, making sure that your friends and contacts are aware of the case and what it means to them, about them achieving the same freedom that the courts have granted to people who live in Quebec. And then pressuring governments to abide by that by actually creating the opportunity for private insurance to develop. Right now, they won't let physicians bill the public system and the private system at the same time, so no insurance company will offer a product here on the private side because they can't get any physicians to accept payment from them. So they use these other mechanisms to go around what the courts have ruled. Of course, when the court rules on something that they actually want to change, they're happy to do that, but when they're opposed to it ideologically, they resist. There was a question.
Yeah, on pharmaceuticals. I've heard it said that none of the rationale background rationale, the Canadians are really being hosed on the price of generic pharmaceuticals relative to Americans.
That's right.
Can you explain that quickly?
Sure.
In a nutshell?
The Patent and Medicines Price Review Board is the federal price control agency for brand name or patented drugs in Canada. It's done some research. The U.S. Food and Drug Administration has done research. I've done research on the top 100 selling generic drugs, top 100 selling brand name drugs. It's a sample of drugs representing 2/3 of the generic market and 3/4 of the brand name market. Very authoritative look at this question. I compared the prices of those drugs on a per common dosage unit basis with the United States. I'm comparing apples to apples. And I found that the price of brand name drugs, not surprisingly, are 43% below US prices. Some people believe that's because of price controls, but some brand name drugs came off of price controls during the period I studied them. And in fact, their prices remained low, the same low rate as the price controlled drugs. So that is, when a drug comes off of patent, it's no longer, you can't apply the price control any longer. That's why it changed. So what that indicates is that federal price controls are actually futile. But aside from that, what I found was that the price of generic drugs were 78% higher on a purchasing power parity basis per common dosage unit comparison. 78% higher in Canada than in the United States. So, because of Canadian government interferences in our market. Our market is simply not as competitive as the United States. We have fewer producers, but even in a market with only one producer, that producer could technically act competitively if faced with the threat of entry from other companies. But in fact, what we find in Canada is that the reimbursement schemes of the provinces, various sort of unintended consequences of federal policy, have allowed big generic companies to buy monopolies on the pharmacy shelf in exchange for kickbacks under the reimbursement that the provinces are offering them. So the province will pay 70% of the brand name price to the first generic entry in the market. So that generic company will kick back 60 cents on the dollar to the pharmacy in exchange for a monopoly, because they have 150 products that they can use on the shelf. That leads to a situation in which pharmacies on the retail level are hosing government payers for drugs, and they're hosing retail payers for drugs to a tune of 78% higher than US prices. US prices, by the way, for generics are the lowest in the world. So people always complain about brand name prices in the States, but they never say anything about generic prices. Lowest in the world. Very competitive market in the States. So that's why generic prices, in a nutshell, are higher in Canada.
Do we have one more question?
Could you go back to that graph that had Luxembourg that was ranked #1? What was that again? I was curious to see if that was some type of machinery that they have more of.
CTS scans.
CT scanners, probably, right?
Oh yeah, the MRIs were Japan. Luxembourg?
Yeah.
Oh, wow.
Want to show us PT scans now? Or PET scans?
CT scans.
Two CT scans.
They're tomography scans. Debbie, do you remember what they're?
CAT scans.
I'm not. Yeah.
Computer assisted
I'm
tomography.
not a physician, so I don't know what they're for. I just know how many
What's
we
really
got.
scary is PET scans, like we wouldn't
Yeah,
be beyond
we don't
it,
show.
because we have, it's so hard. I
They've
think
not
there's
been
two
proven
places.
yet, it can.
Well, there are two places in Ontario, the last time I did research on this, that you can even that.
Sure.
It's true.
It's actually interesting on this graph to look at Japan. The bar goes to the maximum on the graph, but it's actually in real terms beyond the maximum of the graph. We just didn't have the room to show it.
All right, I think we're going to go there.